Good morning and welcome. I'm Fatima Atik, Honorary Fellow with the Policy Insights Forum. The Forum is a nonpartisan research division of Samuel Associates. The Forum helps improve policy and decision-making through research, analysis, and engagement. Samuel Associates is a trusted advisor to many influential businesses working in health sciences, professional services, defense, and other industries. The firm advises leaders on strategy, and new market development, and government relations. Today's public event is entitled Lessons from the COVID Pandemic: How Technology is Helping Healthcare Systems Meet Staffing Challenges. As we have all witnessed, prior to COVID-19, individuals, businesses, and governments increasingly relied on disruptive technologies, especially digital platforms, for a variety of activities, including financial transactions, logistics, education, and of course, healthcare. The first few months of 2020, however, we saw increased usage of technologies. Compared with usage in the first quarter of 2019, the usage of mobile internet grew faster in the first quarter of 2020 as citizens, governments, and businesses experienced dramatic changes in how we interact as a result of the pandemic and lockdowns. A report on the impact of COVID-19 on destructive technology adoption by the International Finance Corporation of the World Bank Group highlights the critical contribution of tech companies to COVID response recoveries across sectors. The report finds that the contribution of tech companies is linked to their ability to quickly pivot towards new services and models, and their ability to expand into adjacent markets and to reach the underserved in a more cost-effective manner than traditional businesses. Despite uncertainties surrounding the economic outlook post-COVID-19, markets are expected to experience an acceleration in the adoption of disruptive technologies and a proliferation of online business models and platforms. The report states that the pace of acceleration will mean not only increased adoption of technologies developed in high-income markets, but also innovation relevant to local needs. In Canada, BookJane Inc. provides an example of tech companies that quickly pivoted its business offerings, expanded into adjacent markets, and reached the underserved in a cost-effective manner to meet a relevant local need, that of staffing our healthcare system. Our special guests today are Michael Lee, Vice President of Operations and Customer Success at BookJane Incorporated, and Major General Jean-Robert Bernier, former Surgeon General of Canada and Director of the Board of Directors of Ontario Health. Please allow me to say a few things about Major General Bernier and his most pertinent achievements to today's discussion. He has chaired NATO's Health, Medicine, and Protection Research Committee and was responsible for health services to military operations, including the Ebola treatment mission to Sierra Leone and the hospital in Kandahar, for which Canada received NATO's highest medical honor. In 2015, he was unanimously elected Chief Medical Advisor to the North Atlantic Alliance as chair of the Committee of NATO Surgeons General. He is the first from outside continental Europe elected to chair the Committee of Surgeons General at NATO and partner nations. On behalf of everyone this morning, I would like to thank you for your service, Major General Bernier. It's truly an honor to exchange with you this morning and to learn how Canadian tech companies can better be leveraged to support our collective recovery. Before we do so, please allow me to introduce our event moderator, the Honorable Jamie Baillie. The Honorable Baillie, is a committee member of the Policy Insights Forum and a senior strategy associate with Samuel Associates. He has a proven track record of leadership in business, government, and the community. As president and CEO of Credit Union Atlantic, he led the financial institution to record levels of profitability and growth. In recognition for his success, he was named in the top 50 Atlantic Canada CEOs for 5 consecutive years. In government, he has served as leader of the Nova Scotia Progressive Conservative Party and leader of the official opposition. He tirelessly promoted greater economic growth for Atlantic provinces and became a public advocate for better mental health services. Today, he is an executive chair of a growing tech company utilizing artificial intelligence to help large charities raise more money. and he is an active member of the Board of Canada Mental Health Association and the Nova Scotia Division. Honourable Baillie, the floor is yours as our event moderator.
Well, good morning, everyone. Hello from rainy Halifax, and thank you, Fatima, for that detailed introduction. I really appreciate it. I do feel compelled to say to everybody that Fatima didn't say a lot about herself, but she is in fact a distinguished lawyer and served at the NATO Allied Command Headquarters, where she was an advisor to the Supreme Allied Commander on his country visits, giving him political advice. So she herself is quite an honorable and distinguished person, and I'm very pleased to work with her on the panel today. My job is to introduce the speakers, starting with Major General Bernier, and I know we're all looking forward to hearing what he has to say, considering his background. And let me just share a little bit of that with you. Originally from Sarnia, Major General Bernier is a graduate of the Royal Military College. After graduation, he served in the famed Canadian Princess Patricia's Canadian Light Infantry, and then went on to study medicine at the University of Toronto. Major General Bernier, just so you know, specialized in medical, nuclear, biological, and chemical defense. So we all owe him a big thanks for his service to our country and to our allies around the world. Outside of Canada, he chaired the Canada-UK-US Medical Countermeasures Coordinating Committee, the Australia-Canada-UK-US Medical Intelligence Analyst Working Group, and was vice chair of the NATO Biomedical Defense Advisory Committee. We are fortunate to have Canadians like General Bernier looking out for us. He also served at the Combat Hospital in Kandahar, Afghanistan, and was awarded NATO's highest honor for medical support for his time there. He is Canada's 38th Surgeon General. Surprisingly, that doesn't mean his warning is on packages of cigarettes, which is what we often think about when we think of the Surgeon General, but he is an honorary medical advisor to Her Majesty Queen Elizabeth II, a job I'm sure keeps him very busy considering she's 95 years old. Throughout his career, he has stressed many operational capabilities in healthcare, including mental health, which is obviously an emerging issue of concern for all Canadians. Major General Bernier is an honorary fellow of the Royal College of Physicians and Surgeons. He is on the board of the Canadian Institute for Health Research and the NATO Science and Technology Board, and also is a director at Ontario Health. So, Major General, I just want to say we're all very much looking forward to hearing your remarks. I hate to tell you we're going to try and hold you to 10 minutes. There'll be lots of time for questions after. Welcome to the panel, and thank you everyone for participating here today.
Great, thank you very much, Jamie, and kudos to Samuel Associates for highlighting this very important subject. I just want to correct one thing though. I oversaw all the health support for southern Afghanistan in coordination with the Americans and the Brits and Dutch, but the award to NATO was to the Canadian Hospital in Kandahar, the first NATO combat hospital in a shooting war, and it was not to me personally. I just happened to be the guy in charge at the time that we got credit for it. So thank you very much. This is a really important subject, but I'm neither an HR nor a technology expert, as some of the participants are. So the comments will reflect only my own personal perceptions based on strategic experience leading health systems, science and technology projects, and public health efforts. And they absolutely do not represent Ontario Health or the Ontario Ministry of Health. And I'll stick to 10 minutes, but I can only do that because I'm such a chatterbox if I stick to my script as much as I can. So everyone recognizes, I think, the importance of technology in healthcare very generally, and some of the greatest and potential developments to revolutionize healthcare in virtual care, big health, data analytics, and technological developments in areas like artificial intelligence, robotics, genetics, synthetic biology, and a whole pile of others. And many of these will also benefit directly public health functions and epidemic management, pandemic management, such as the use of digital tools for epidemiological surveillance with web-based intelligence and syndromic surveillance, especially. Many of these things already implemented by some armed forces, some public health agencies, and jurisdictions in continental Europe and in North America as well. Rapid case identification with with things like wearable sensors, connected diagnostics, the interruption of transmission of disease with phone apps for digital contact tracing and geospatial mobility pattern analyses, the use of the internet for targeted and personalized public communications, and many other telehealth applications, some of which have been developed here in Canada. But I want to comment on tech applications specifically to HR management, since health system performance depends so heavily on the availability, the knowledge, the skills, the fitness, and also the motivation of those who are responsible for delivering public health and clinical health services, and many arguably more so in importance than the physical resources necessary. Most health organizations today use human resource information systems to support the routine operational core HR practices, but many now, or most maybe, also use them more strategically for recruitment, performance, learning and development management, succession, and workforce planning, not just to automate tasks, but also to increase productivity through lots of means. One is smarter working models like telework, that's so prominent now across the world, wellness programs, performance management, employee feedback tools to engage the staff, to increase their satisfaction and productivity, to gauge their morale and reduce the costs of burnout and turnover and having to retrain new people, and to support retention and recruitment, which is so critical. Another is the use of more devices and applications than just email for better communication and collaboration of staff. The use of virtual reality and simulation for training, as well as other online and modular training to reduce costs and inefficiencies, and also to reduce the dissatisfaction related to travel and fixed training times that many staff don't like. Performance management and rapid current tracking of certifications and licenses to support the quality of care and patient outcomes, given the increased risks, especially now arising from virtual care, home workplaces, expanded scopes of practice for some people, and inter-facility deployments, at least in Ontario, all of which call for meticulous regulatory compliance. Also, they can help with faster automated recruitment processes, and most importantly, in the context of inadequate human resources in a crisis, particularly in jurisdictions like Ontario's, strategic workforce planning and the optimization of the employment and tasks of our limited HR task force. So how's COVID specifically increasing the importance of technology for health system HR management? Well, HR for all industries has had to cope with new challenges because of COVID in protecting health and mental health of their employees, ensuring business continuity, complying with frequent government and public health policy changes, and supporting the transition to remote work. But its adoption has been especially critical to health systems for many reasons. Well before COVID, the benefits of technology were obvious to enhance productivity, efficiencies, and cost savings, effectiveness, especially given Canada being so far behind certain comparable nations. Our health systems in Canada are generally behind other Canadian industries in that regard. There are unsustainable health expenditures that have been coming up for a long time from aging demographics, increasing chronic diseases, and the increasing costs of implementing new clinical capabilities. Provincial efforts at system transformation and integration to enhance patient experience and population health and value for money, all of these were being slowed down or obstructed by vested interests, the inertia of government bureaucracies in Canada, and political considerations. But COVID has given a certain urgency that negated many of those obstacles and necessitated technological and policy updates to support health system integration and efficiency as a matter of life and death. So as Ontario Health and some other provinces have been able to show with great significant expansions of telehealth, virtual care, digital systems, and back office HR support, as well as the integration of many agencies, labs, and other duplicative system silos, at least in Ontario, but also in Alberta and in British Columbia. There's a political window of opportunity right now to rapidly modernize and optimize the system, including HR management. So now is the time to try to implement technologies that are disruptive to the usual inertia and status quo. Another reason is the massive post-COVID government debt is going to further increase pressures to maximize health system integration, to rationalize health budgets, and to optimize value for money, staff competencies, distribution, and employment, and all the other costs related to HR management functions. Greater integration is also being supported just this week in Ontario by the Ontario Attorney General's Long-Term Care Audit Report and the testimony of witnesses to Ontario's Long-Term Care Commission. So depending on the extent of integration decided by government, it could potentially involve provincial consolidation of some HR management technological elements in some areas like digital information, HR programming, finance, and other back office support systems. That's already happened in many other jurisdictions. In Ontario and elsewhere, unmet COVID-related HR capacity demands have really increased pressures for recruiting, retention, and rapid optimal staff scheduling and frequent rescheduling as staff miss work either by choice, by burnout, or by becoming infected. And the integration of new workers like international medical graduates, retired folks, accelerated trained folks, and volunteers, new categories of volunteers in some cases. So Ontario's recent public staffing commitment for 27,000 more long-term care staff, 30,000 more long-term care beds, and the accelerated training of over 9,000 public PSWs, personal support workers, that could increase pressure as well on the HR management burden, particularly for those with less capable HR information systems and management capabilities. There are also HR management implications from healthcare workers having to work understaffed outside their normal scopes of practice because of the demands of patient care, for critical care especially, outside their own facilities because of transfers that are now authorized to be mandatory by the provincial government, and providing virtual care. For example, in Ontario, just last year, there were 6,700 new virtual care user accounts and 28,000 virtual cognitive behavioral therapy patients. So all of that requires more training, tracking of training, qualifications, licenses, and certifications. And because of the many unknowns with new infectious agents and the long timelines to recruit, train, and deploy staff, the ongoing epidemic modeling by public health authorities is also really important to HR management in helping forecast and plan for future staff mix, volume, competencies, and deployment requirements. And then the unprecedented burden on staff that this is posing, especially the clinical care frontline staff and the public health functions in contact tracing and other areas, is also generating levels of stress that could manifest in extensive post-COVID and intra-COVID turnover, mental health problems, later on disability claims, maybe litigation, and other problems. And even more so if a clinical triage protocol has to be implemented and exercised where there's insufficient care capacity for all the patients who need it. The mental health burden of having to decide who lives and dies in those, who gets an ICU bed and a ventilator, could have significant mental health consequences for the staff. So that really highlights the incredible importance of effective employee assistance programs, wellness programs, and especially their supporting technology to maximize their reach and availability. Makes them all more important than ever, with over, in Ontario last year, 3,000 healthcare workers using Ontario Health's COVID frontline worker wellness service. So investments and adaptations to digital support workplaces are requiring some of the HR systems to track and validate work now, to validate occupational health and safety sufficiency at the home office, and the competency acquisition at home through virtual learning. And given the related efficiencies, though, and the cost savings and satisfaction for the staff that's suitable to work at home, this will likely continue to some extent post-COVID, possibly to a great extent. For example, the College of Family Physicians in Canada and the Royal College of Physicians and Surgeons that oversees specialists, they had to rapidly develop remote ways of using technology to assess and certify physicians after residency, such that their multi-year, like 5-year plans to fully develop and implement that had to occur in weeks and months. Telehealth, virtual care, and Ontario sub-regional integration of most of the local health system elements into Ontario Health teams that's taking place now. And all of that will come under a single bundle budget and a local leadership model. All of that may present further HR management challenges, given that it'll involve the integration of many different partners with different benefits, policies, insurers, bargaining units, and the extent of necessary inter-facility interoperability in information management and HR management systems. So these are just a few of the COVID-related factors that just come to mind to me right away that are relevant to the importance of technology in health, human resources management for future demands to optimize the capabilities and the employment of scarce staff today, but also in the future, and to accelerate the adaptation to changes in policy, capacity demands, and operational priorities that are occurring now and will in the future. So I'm sure that many of you could note many other implications that favor the adoption of HR management technologies. But now I'll turn over back to Jamie to carry on with the program. Thank you.
Thank you, General Bernier. That was an insightful and helpful walk through the challenges that we're facing in our healthcare system overall, and putting them into the context of the current COVID pandemic is very helpful. The topic today is actually how tech is helping Canada and its healthcare system meet the challenges that it has had before COVID, and particularly during the strains of COVID. And so now we're going to look at a specific example of a Canadian technology that is helping in a very real way on the ground in meeting that challenge. When you think about it from a global perspective, the fact that we have at least 4 vaccines available to us a year into the pandemic from Pfizer, AstraZeneca, Moderna, and Johnson & Johnson is a pretty impressive global technology feat, something that could not have been imagined even at the beginning of the pandemic. That's a global achievement. But here in our own country, there are Canadian tech companies that are stepping up. As Ontario Premier Doug Ford challenged them to when he asked companies to answer the call to assist the government and its healthcare agencies in serving Canadians during this time. One such company is BookJane Incorporated, which is a shift fulfillment company that has been using a new technology to help long-term care facilities, public health agencies, and hospitals and others fill their shifts and optimize the use of their health human resources. So we're very fortunate today to have Michael Lee, who is a CPA, CA, an impressive credential. Michael Lee is the Vice President Operations and Customer Success for BookJane. He is a graduate of the University of Waterloo. He did his CPA training at KPMG and then at TD Bank. Prior to joining BookJane, he held a senior role at Finastra, which is the 3rd largest fintech company in the world. And so if we get a chance, we might ask him to tell us exactly what Bitcoin is anyway, but that's off topic. Right now, I'd just like to welcome Michael Lee to our panel and invite him to take us through what BookJane is, this impressive Canadian technology, and how it is helping us battle the COVID pandemic. Michael.
Thanks a lot, Jamie, for the introduction. I promise we will not get into Bitcoin today. But first of all, thank you for Samuel Associate for putting this event together, and to Major General Bernier, looking forward to sharing the floor with you. This is a topic that's near and dear to my heart in terms of how technology can really help with our healthcare system in optimizing the human resource function, because I think that's an area that tends to be overlooked. And I think you brought it up earlier, where we typically think of technology as this sophisticated thing where it's artificial intelligence, it's smart ways of scheduling, patient management, virtual care, etc. But what's overlooked is, especially in healthcare, where a lot of these service delivery is really happening at the frontline staff. And what BookJane really is we're looking at tools to make their lives easier. We're a technology-enabled solution to help them provide better care. And so just a little bit about BookJane. We've been, we're Toronto-based. We've been in business since 2016 for the last 5 years. Our main focus is really mass mobilization and rapid mobilization of healthcare resources to be deployed into healthcare facilities such as hospitals, long-term care homes, vaccination clinics. That's another thing that we start to look into. And on top of that, we're really looking at how do we empower the frontline, giving them the flexibility to not worry about a lot of the administration tasks that they have to start to do. And COVID's made that even worse. And so we all hear about burnout of that frontline staff, and it's not just providing patient care. The administration tasks that they've been doing has exponentially increased over time, and it's leading to burnout. And what BookJane is aiming to do is really reduce a lot of that administration, so that they're not spending hours of the day making sure somebody's coming in to a particular shift. They can just really focus on providing patient care, which is really what they're specialized to do, and that's what BookJane aims to do. So we're a technology that tries to provide better care via staff scheduling. COVID is something that has made this challenge even higher. So we know that in healthcare there is a supply crunch. There's not enough nurses, not enough physicians. We got to make do with what we have, and technology can really start to enable that. And so we're starting to see a lot of health systems start to adopt these tools, where they're starting to recognize that technology can really help in this battle to really take the burden off of the healthcare professionals. So Jamie, I'll pass it back to you. That's kind of that, and looking forward to our interactions with Major General Bernier.
Thank you, Michael. That was great. We're right on time, which is terrific because we want to leave as much time for questions as possible to our panelists. I will say, just before we get to the questions, I'm so pleased we're doing this. This is a nonprofit effort by Samuel and Associates to create discussion in areas of interesting public policy. There's been a number before this. For those of you who are tuning in for the first time today, you should check out our website to see some of the topics that we've covered in the past and some that are coming up in the future. But ultimately, our goal as a public affairs company is to contribute to the great national discussion about emerging issues, whether they're in national defense and security, or in healthcare, or in any number of other topics of importance to the nation. As you can see from this one, we're trying to combine that with some examples of practical, on-the-ground, frontline applications that come out of these discussions, like BookJane's platform and how it's working on the ground in a number of instances here today. So people are welcome to submit their questions. We'll get to as many of them as we can, maybe not in the order they're submitted, but I'll do my best to sort through them. We had a number of pre-submitted ones, which I'll mix in with any that come from the floor, as much as it's from the floor in an electronic way. But first of all, just to lead off, Major General Bernier, you spoke about our healthcare system, both in general and the challenges it faces, and specifically the COVID challenges it faces. Could you share with us what has the COVID pandemic taught us about our healthcare system that we didn't already know, and our military preparedness for national crises such as these in the future?
Well, others will have a closer perspective on several elements of it, particularly some of the details. I'm at the 30,000-foot strategic level. But one key thing is the dedication of our healthcare workers to adapt and to expand capacity despite a very low national surge capacity, the consequences of some, especially federal political misjudgments in the management of COVID, and how far behind we are, I think, in the use of technology to relieve clinicians of administrative burdens, which you can, at least in some defense departments, we were able to quantify the cost, the loss in cost, efficiencies, et cetera, of having imposed so many administrative burdens that could be automated, in theory, with technology, or passed on to more optimally organized. The Roman legions had the best medical system that wasn't equaled until the late 19th century because they didn't have the science we had. They didn't understand why certain diseases occurred, why certain treatments worked, but they had a very close empirical observation culture. But the key thing was their HR management functions, the way they organized training, knowledge translation, information management, knowledge translation, training, career progression, all that kind of stuff. So the HR functions are critical. Another is the wisdom that we've learned of maintaining relatively inexpensive versus the cost of COVID are going to be astronomically or several orders of magnitude more than if we'd simply maintain adequate public health capabilities and rapidly approved the time or applied all of the time-proven fundamentals of epidemic readiness and management. The number of lives that could have been saved if we'd done that early on. The wisdom of the SARS Commission report way back on recommendations for public health official autonomy and authority with less political factors are critical, but politicians have the authority, the only electoral mandate to make the difficult decisions combining economic considerations, health considerations, et cetera. But nevertheless, capabilities are degraded in between crises, and ultimately it's the scientific decisions. If the more they're applied early on, the less the economic consequences will be felt, as occurred in so many nations, the 10 top nations that have had relatively little damage as a result of COVID to their economy and to their ongoing social interactions. The need for system integration and the elimination of, in some jurisdictions, thousands of independent and duplicative silos. Again, HR management technology, the integration of it into one system can save, and has, for example, Ontario Health, just with the limited back office integration that it's done so far of about 21 agencies, has saved close to $500 million, and will be saving more as more occurs. So going down from one, for example, virtual training system down from 500 down to a single one, or finance management, or all elements of HR management, that can accelerate, increase effectiveness, efficiencies, cost savings, redirection of limited resources to where it's needed. The wisdom of public health crisis communications, some of them have not been followed throughout this crisis, and they're well known, particularly the importance of having a public spokesperson who's an expert that the public can trust. With respect to military preparation, I'm too far removed now. My last job was Surgeon General for NATO, for the North Atlantic Alliance, and I was too far removed from specifics in Canada. But my experience in the fundamental elements of the military mission and culture generally results in its ongoing maintenance of crisis readiness, very rapid crisis decision-making in ambiguity and uncertainty, and action, rapid action, and maximize protection despite those ambiguities and uncertain information. And it's a very unique general intelligence and medical intelligence capabilities, and its readiness mission also support careful ongoing international health surveillance that failed in Canada, and to protect it from delusions about the reliability of reports and assertions by governments like that of China, or by the WHO, which politically and diplomatically has no choice. It can't contradict the public reports of sovereign nations, which is a key reason why Western nations maintain medical intelligence services with independent means of verification rather than just relying on the statements of various governments. And media has reported on that earlier. So, and finally, the national need for independence and technological capability development, whether it's vaccines, HR management technologies, and all that kind of stuff. We need that kind of capability in Canada, and we need to implement it. So I'll just stop there. I could go on, but there are many other lessons that are.
I do want to add on. I do want to add
Michael.
on there because I think Major General highlighted a key point in here, especially in the pandemic scenario. Coordination is key, and that's what we saw. And what we saw is the frontline workers, and my goodness, like, just thank goodness to them. When the first wave first started happening, we were working with the Ontario Medical Association with doctors, and we're trying to solve the problem. And how do we quickly mobilize a workforce if we need to do build up a pop-up hospital? Thank goodness it did not happen in wave one. But what ended up happening was they put out a communication out to their membership. 2,000 doctors signed up within 1 weekend. So that's how many people. So people are willing to help. The physicians are willing to help. Biggest challenge is the coordination. And I think the other point that was mentioned there was just the administrative burden in coordinating that when systems don't exist, and the numbers, the cost associated with that is staggering. And that's where technology can help, right? Where you can put in a system out there that technology is really doing the work, where the administration staff doesn't have to ensure that, oh, somebody's going into this hospital, somebody's canceling, etc. It's got to be a rapid strategy to be able to deploy staffing quickly.
So, Michael, thanks for that. Why don't you share with us a client example? You don't have to name them if you don't want to, but where BookJane has actually done what you two have been talking about, which is apply modern technology to some of our traditional staffing challenges in healthcare.
Well, I'll bring up a recent example. So, right now, one of the biggest urgency within Ontario is just vaccines. How do we deploy vaccines quickly? So we've been working with a lot of public health units in just, talking to them about the solution out there. And so what we know of physicians and healthcare workers is they're stretched thin everywhere and all over the place. And if I talk about primary care physicians, they still have their own practice to run. Yet these are the doctors that we want to deploy those vaccines. So, one public health unit that we worked with, we showed them our solution, which is, here is a mobile app where you can access thousands of physicians at once, and they can pick and choose the times of which that they can work, and they're really working on a casual basis. They're really volunteering their time to be able to help deploy vaccines into the community. We got up and running in about a week's time. We got I think the number was just under 500 doctors in this particular region. It's actually a hotspot in Ontario, and they had the next 2 weeks completely booked, fulfilled, without any interaction from their staffing and administration team. Next 2 weeks are booked up 100%. And as supply started to come in, they were starting to book 3 weeks out, 4 weeks out. And even if things change, if a physician says, I can't make it to a particular shift, the technology is taking care of that. Where if they cancel a certain shift, it's going out to the other 499 physicians so that somebody will pick it up. And so that's what we're trying to do to help out with the deployment of vaccine, because that's probably one of the most important things to really tackle this pandemic, is how do we get the vaccines out into the community as fast as we can for the people who want it.
Michael, just to follow up on that, the general talked about integrating new technologies into our old systems, which of course is always a concern when we're trying something new. Can you talk to us about the integration process, whether it's a long-term care home or a public health agency or a hospital? How does BookJane sort of graft onto their existing HR systems?
Yeah, I think when people think about integration, they think of this massive task that takes months and maybe years to do. The cool thing about technology is that's changed a lot. Where with the introduction of cloud-based technology, you can get up and running relatively quickly, and the user experience is great, where you see that user adoption. And when you talk about integration, it can happen in multitude of ways, where certain times you don't need a real-time integration, and that's how you can get around that relatively quickly. So BookJane will work with our health agency to say, what is the key problems that we're trying to solve? Is it just alignment of who's that particular staff? How often does it need to happen? And that's something that we can get up and running relatively quickly.
Great. General Bernier, I have to ask you, how worried are you about the future supply of health workers, the state of stress and exhaustion that they're feeling now, excuse me, during the pandemic? And what can we do to support our frontline workers as we get through the pandemic and once we come out of it, to make sure we kind of optimize their work experience?
Well, the WHO is forecasting by 2035 a shortage of almost 13 million healthcare workers. The situation in Canada, budgets in a system like ours that's controlled centrally, single user or single payer system, there's necessarily some balance, like many continental Europeans, the National Health Service in the UK. There's a certain, I won't call it rationing, but there's a planned health landscape to try, health service landscape to try to optimize the value for money. And so we're always going to be in a situation, particularly as the debt that was already enormous and now is dramatically greater as a result of COVID is going to restrict the availability of health services. That can be compensated with a lot of, there's various means. One is the deployment of discrete medical functions to other healthcare providers. And I was encouraged this week to see that Ontario will be regulating physician assistants and PSWs. And I'm hoping that they'll do like many armed forces have done and expand the scopes of practice of others. But another critical measure is the use of things like artificial intelligence and other forms of technology to relieve the burden. And based on following on what Michael was saying, for example, to increase capacity of treatment between Canada and the US Northern Command organized way back after 9/11 a civil assistance program between Canada and the US to overcome all of the obstacles with a heavy reliance on technology to permit the interoperability and integration of Canadian clinicians into US states in emergencies very, very, very rapidly, simply on the authority of a state governor. So all of the differences in HR management, in insurance, in liability, in clinical authorities to practice, integrated training, integrated deployment of multinational people from different organizations and medical cultures and legal was made possible and exercised in various hurricanes in South, where Canadian clinicians went down there, and US military medical facilities, entire ones, were able to be deployed into BC during the Vancouver Olympics. At the NATO level, we integrate clinicians from not just the 30 NATO members, but also from another 20 partner nations with all different medical cultures, socioeconomic, medical, legal structures, everything else, HR systems, by the heavy use and pursuit of technology to facilitate, maximize the automation and the integration without having to do millions of hydraulic interactions on paper to overcome all of these things. But all of this done, to be valuable, all of this has to be done and put in place before a crisis occurs. If you try to develop the technology and implement it in the middle of a crisis, a lot of folks are going to die unnecessarily if people had the foresight, institutions had the foresight to have in place that technology beforehand. So that's one of my concerns. The other, of course, is related to other things like independent national capabilities in various medical products, pharmaceuticals, equipment, but especially research and technological development capacity.
We actually have a question from the floor, and I'm going to ask it to both of you, but let me start with you, General, because you did mention SARS earlier and your experience with SARS. So I want to thank Michelle for this question, because there is a sense, I guess, across the country that we didn't really learn from SARS and the other health crises that we faced. So starting with you, General, in your opinion, what are the most important lessons learned from this COVID crisis that we'll need to deal with before there are future health crises?
Well, I'm often cynical because, as a British Director General of Hygiene of the British Army once said, history, when it comes to public health, history teaches us that we do not learn from history. So there's always an investment in public health and readiness and crisis capabilities after a crisis occurs and during a crisis. And then, as happened with the Public Health Agency of Canada, within just a few years, and the SARS Commission recommendations, within just a few years, it started being dismantled, the improvements that had been made, to the point where, as has been heavily reported by the media and the federal Auditor General, the Public Health Agency lost the capability to fulfill most of its critical key functions, the reasons for which it was established. But that's where you rely on the human bureaucracies, and human nature and political considerations will always require us to focus on the issues of the day, the pressures of the day. And so I could see, if I was in a federal Ministry of Health or elsewhere, the need to reallocate resources to current issues that are of greater interest to the public at the moment in health, that would be the thing you have to do with limited resources. If, however, you can delegate, you can establish a technological infrastructure that maintains a lot of capabilities, regardless of decisions, that allow you a rapid ramp up and rapid efficiencies in staffing, training, et cetera, analytics, everything that might enhance the capacity with fewer health care workers to achieve greater effect, clinical effect is great. And technology offers that today. But because of inertia and bureaucratic, particular bureaucratic inertia, but also the conservatism of the health community in general, and vested interests, because any change that to enhance the care to people does ultimately threaten potentially some occupations and the way of doing things, and people don't like that kind of change. But when it comes to public health and readiness for crises, I think investment in technology to support it and to just generally be able to provide the health system a surge capacity is a critically important thing.
Michael, I can see you're anxious to jump in there. Go ahead.
Major General hit on a couple of points, and I think with the pandemic, it created that urgency and the necessary of change. And I can tell you, pre and post pandemic, the customers that we're talking to react a lot differently. And I do hope that the pandemic is able to shine a light to say, hey, technology can really help. And where we went to how we let our guard down after SARS, I think it was like 10 years ago. After about 2-3 years, like, oh, probably not going to happen again, and it did happen. And hopefully what I see as a technologist is that we invested all this time in the last 12 months to say, hey, there is a better way of doing things via technology. The cost burden is real, like in terms of all of the government subsidy that's been coming on. There will be cost pressures, and hopefully what the technology is able to do is actually make us more efficient, such that the tax dollars that we're spending on here is in the right ways, into care, into training of new people, as opposed to what I'm going to call administration tasks that add very little value to the healthcare system.
Michael, BookJane, of course, existed before the COVID crisis. What lessons has your firm learned as it serves your clients during COVID that you'll take into the future?
I think we learned that, before we were mostly in long-term care and senior homes. What we started to see when the pandemic started to hit, and when we started to talk to Ontario Health, the Medical Association, as well as the hospitals, that this can really apply in a lot of different settings. And what we're really looking at, and really my role at customer success, is really working with our customers and saying, is there a better way of doing things, and really challenging them on the change. The change management component is something we look at every day, every time we look at onboarding our customers, because the technology itself is actually not that difficult to implement. It's changing the mindset of where it is. And that's why forums like this is important for me, and for us, to be able to make sure we keep our foot on the pedal, that we got this momentum on the change, and we continue on that.
Sure. And again to you, Michael, we've been throwing around the word optimize or efficiencies a lot in the last hour. Give us which I think for most people means do more with what you have, or even do more with less sometimes, productivity gains. Can you give us an example of a client where they've seen a significant productivity gain, or in terms of optimization or efficiency, as a result of using the BookJane platform?
Yeah, I'll give an example. Many clients see this, and so a very real example is, pre-BookJane, the way they deal with scheduling and workforce management tend to be fairly manual. So they'll have a scheduler that their full-time job is to make sure that staff is showing up. And when things change and life happens, and especially with COVID, when 40-50% of their staff ended up having to self-isolate, they were panicking. They did not know how they were going to get people in. And so what technology can do, as opposed to what that one scheduler calling one casual worker at a time or emailing them or sending them texts, is technology can access thousands of people within 2 seconds. And so that's the degree of savings that we're looking at from an administration burden. And so to make matters worse, and let me make it real, is pre-BookJane, the scheduler is doing that full time, and sometimes because 50% of their staff's not is absent, it actually leaks over to their clinical teams. That's when it becomes a problem, when you have nursing staff dealing with administration tasks as opposed to caring for residents and patients. That's when it becomes a real problem. And so for us to take this 2 to 3, 5-hour administration task to a matter of 30 seconds, it drives an incredible amount of change and savings in time.
Thank you. General Bernier, you are both a military officer and have served or are serving on the boards of a number of Canadian healthcare institutions like Ontario Health or the Institute for Health Research. In your opinion, what is the best way for a private Canadian company like BookJane or others to make themselves known to our government officials, both provincially and federally, as part of the solution to the stresses that we have in healthcare today?
I think it's publicly well known what they're looking for, and everything that has to do with the key goals of enhancing patient experience, enhancing public health, population health level, at the population health level, enhancing provider experience as well for healthcare workers, but value for money. Value for money is the big one. Population health and value for money. But all of that, and it's governments are looking for avoidance of duplicative silos. So there's a greater push for integration. Alberta's done it, BC's done it, Ontario's doing it now. To various degrees, other provinces have done it. Some of the continental Europeans, even at the national level, have a full integration with massive cost savings and efficiencies, with far less of their GDP going to healthcare as a result of integration. But what they're doing is using technologies that have proven themselves, either developing them from scratch over a prolonged period. But one of the critical factors, I think, for industry is that it's got to be able to have measurement built into metrics built into its technology and ongoing surveillance and collection of those metrics, and to be able to objectively, quantitatively demonstrate to government authorities the effectiveness and the cost benefit of their technologies, but not just with respect to financial elements, but increasing the whole clinical capacity, the clinical firepower of getting more treatment and greater population health effects to the public. And anything that can relieve administrative functions. One of the greatest complaints of clinicians in the world, but certainly in Ontario and in Canada, is the amount of time that they could be spending treating patients, that they're spending either the clinicians, but also the administrative staff having to do repetitive functions that technology can automate, and that in theory, and those systems that have automated them, like many in continental European nations, have resulted in very significant savings and just a greater standard of healthcare for the general public. So I would say one of the most critical things is the metrics, being able to quantify and be interoperable with other systems. Given that inertia is often not going to permit the application of the procurement and application of a single technology to a whole, say, big province, it may result first in certain smaller sub-jurisdictions, but then if that jurisdiction is showing significant savings because of the metrics, it's more likely to lead to the government authority that looks after that area, that's responsible for that area, to focus down, especially if there's a request for proposals to be submitted, that technology can demonstrate objectively with champions in the healthcare system who are responsible for the delivery of healthcare, if it's being championed by them rather than the firms that are selling or developing the technologies, then all the better, the greater the impact it will have.
That's great. Well, so Michael, the last word's going to be yours. The gauntlet has been thrown down by the general on how to make the case to government officials. How is BookJane responding to those requirements?
I think the general mentioned it. I think it's working with our healthcare leads. Have them tell the government, technology is helping, rather than having it come from BookJane. The ones that have been implementing BookJane, and some of them have been using our technology for the last 3 years or so, significant changes in how they manage and empower their staff. And what the general said about clinicians saying they're distracted by administration tasks, that's real, right? So if we think about efficiency, even if you can reduce their administration burden by half, right? That is care that you haven't increased any additional capacity, but just making them more efficient to be able to deliver patient care is incredibly important. And so for us to be able to do that, and we quantify everything within our system, not just the amount of shift fulfillment that's going through, but also how much of that time is being done for patient care. Because if you can elevate that, that's ultimately what matters for any healthcare system. Is are your healthcare providers happy? Are they going into work and providing care, and then providing the best care possible for the resident and patient care?
Thank you. I did say the last word, but I take that back because the questions are continuing to come in, and I think we have time for one more before we wrap up. This is for each of you, and feel free to use this to make any final comments that you want before our time is up. But I want to thank Georgianne for this question, and it is this, and I'll start with you, General. Is it fair to say that much of the crisis in healthcare today could have been avoided by the implementation of technologies that focus on managing personnel and patient allocation and flow?
I don't think so. It would have relieved and made a response more efficient. We would have had, I think, possibly some lives could have been saved. But they're bigger issues, I think. And I won't comment on provincial. I'll never second guess. When I was commanding a military hospital, I would always ascribe nefarious motives and incompetence to some of the decisions coming out of Ottawa, especially from the military public health agency, until I got to Ottawa and was working in that public health agency and led it at one point, and had to make those decisions myself in consultation with the military leadership and the politicians. And the decisions were the same ones that in my ignorance I had condemned as uninformed and incompetent before. So I won't second guess the decisions that public health agencies make and that politicians make, because without knowing the specific information of all the hundreds of different factors they have to balance, without knowing all of the information, all the details, I'm absolutely not competent to comment or criticize those decisions. The media, though, and the Auditor General have well described objective failures at the federal level, things that all provinces rely on and cannot deal with independently. So for those, I'm only commenting on those that have already publicly been presented by others. And HR management technologies were not part of those criticisms, because they're largely controlled at the provincial level. But certainly if we had better HR management of our people, our limited, most critical resource in the management of any health crisis, to make it more efficient, where we direct resources to the right place at the right time with the right skill set, which HR management technologies can help, then yes, I think it would be a fair statement to say that things would probably have been better in many independent individual circumstances, which vary so much by region, the prevalence and incidence in different regions of vulnerability of populations. But generally, as an overarching statement, yes, I would say that better HR technology implementation across the board as variable as it would be across jurisdictions, would have made it better. For example, if you just look at what Taiwan, South Korea did with technology, with its rapid implementation, or preceding COVID, already had some of those technologies implemented to support public health. And the results of them and other jurisdictions that were similarly prepared and more technologically astute and ready shows the contrast between our response and theirs.
Thank you. Michael, this time I mean it. The last word is yours. Could implementation of new technologies have helped alleviate the crisis, particularly in HR, human resource management? Take it away.
I think hindsight is always 2020. I think could more have been done? Yeah, but I think we did what we could in a short period of time. I remember 12 months ago when COVID first came up, we didn't know what we were really dealing with. And I do think that the change has started to take place in terms of the momentum that's happening. I do hope that the government or the healthcare system is looking technology in a new way, as as not this big scary implementation that needs to happen, but something that can really help coordinate the efforts better with the healthcare providers. And I think the coordination is key. Too often, I think when a crisis happens, the natural reaction is just react and really separate things into silos, but a coordinated effort makes us more efficient as a whole. And I think technology can absolutely help with that and reduce the burden on both the administration and also on the healthcare provider itself.
That's great. Well, we're actually a few minutes over time, not too bad, but thank you to both of our panelists for your presentations today and for taking questions that were both prepared and from our audience. I hope everyone that tuned in today got something important out of the talk. That's one of our goals here with these policy forums. So thank you very much, gentlemen, and I will throw it back to Fatima to wrap up.
Thank you. On behalf of the Policy Insights Forum and Samuel Associates, I would like to thank our special speakers today, General Bernier, former Surgeon General of Canada and Director of the Board of Directors at Ontario Health, and Michael Lee, Vice President of Operations and Customer Success at BookJane, and our event moderator, the Honourable Jamie Baillie, for an outstanding discussion. It's truly a unique opportunity just to be able to hear from such diverse backgrounds, experiences, and deep insight and knowledge about critical issues of our time. So to our audience, I thank you too for joining us this morning, and please visit us at policyinsights.ca. I'm Fatima Atik, and we look forward to seeing you again.